Good morning, everybody. Welcome to Grand Rounds. I assume we have quite a few people watching remotely, but I've been promised by Dr. Barron that his mom is actually watching from Naples, Florida. So good morning, Mrs. Barron. One kudos before we start, and that was for Eli Sayeg, and it's from a parent of Seattle Children's Hospital patient. Good morning, Eli. And the compliment says, my daughter is currently recovering inpatient from a spine surgery. The orthopedic staff at Children's Hospital has been great for this procedure, but we have particularly appreciated the care given by the resident, Eli Sayeg. Eli has a good bedside manner and is compassionate. He entered the room quietly, introduced himself clearly, patiently listened to us, and responded to our concerns in an appropriate way. It was much appreciated, so thanks again, Eli. With that, we'll start our grand rounds today. This is our slightly modified format where, after receiving some feedback from faculty, we've shifted a little bit back to the model of the residents being more involved in putting together the grand rounds. We still want to partner them with a faculty member, but as opposed to having two faculty members, we'll now split the grand rounds approximately in half and have one resident, one faculty member. So today's talk is distraction, osteogenesis, and Ilizarov techniques. And the speakers are Matthew Barron, who you all know as one of our four residents, and then Michael Githens, who's an assistant professor at Harborview. And Mike has been here for almost a year now, or just over a year, yeah. And he's been a great addition to the faculty. So we'll start with Matt Barron introducing the topic.
Thank you very much, Dr. Chansey. Thank you, Dr. Githens. What we're going to talk about today is distraction, osteogenesis, and Ilizarov techniques. This is my outline, but in essence, what I'm going to tell you is a fantastic story about the discovery of a new process of bone genesis within medicine through the field of orthopedics. And I hope you will share some of my enthusiasm. Okay, very, very briefly, a little bit of background. I'm sure everybody has already learned this many years ago. Bone forms classically through two pathways: cartilaginous hypertrophy and direct differentiation of osteoblasts. This is a different type of bone genesis. You have two ends of a cortical shaft osteotomized in a scientific experiment by Dr. Ilizarov. And what you can see here is bone forming through an entirely different formation pathway. A little bit more, these two ends of bone are under stress. They're in distraction. It creates an environment of tension, and that is what he thinks is the reason this bone regenerates in between, in this interzone. In that interzone, new bony trabeculae form, and they form in a distinct parallel orientation to the distraction force, which we'll talk about more. And that goes on to consolidation and cortication. Before I get to Dr. Ilizarov, who I thought was the person that invented this person, an Italian surgeon, very well may have been the original surgeon to use this type of treatment. He also described the first iteration of the Whipple procedure. So he did a few things. This is a paper he published in the early 1900s in English in what's now known as JBJS. He was the director of the Rizzoli Institute in Bologna. And in 1902, he introduced a method of skeletal traction to treat chronic deformities of the leg, in opposition to another figure at that time, Steinman, who was using it for treatment of acute fractures. This is a diagram. It is not a medieval torture device, but it is his traction setup that he used to stretch the limb after he performed an open osteotomy of the bone. And here's some quotes from his paper. I'll let you read it, but in essence, it shows an extremely deep insight into this process. He talks about separating curved ends of bones, but the trouble being in lengthening of the bones, striving to overcome the resistance of muscles without damaging the soft tissues. And at the very end, it's his opinion that it's applying the force directly to the skeleton. So it's amazing how much insight he had in the early 1900s. A little bit more. I found it very fascinating that he performed his osteotomy at Ciniera. That's Italian for the turning point, which is sounded incredibly similar to the cora, center of rotation and angulation. Traction was applied through the calcaneus, lengthened slowly, an average of 20 days, something not dissimilar to what Dr. Ilizarov is what we're going to talk about with Dr. Ilizarov. And the inspiration was really to avoid the damage that was seen by plaster. He was doing the same process by performing an osteotomy, stretching a limb, and placing a plaster cast, and then slowly redoing that every few days, and that was causing a lot of skin troubles. All right, so now I'm going to fast forward. This is post-World War II, Kurgan, Siberia, Russia, or was then USSR. And this is a later picture, Dr. Ilizarov. At that time, he was a new medical school graduate. He was stationed in that remote area where he began training in surgery and orthopedics. He encountered some extremely difficult cases of traumatized limbs and post-traumatic limb deformities from the Second World War. And his work first began in methods to stabilize a limb and avoid the complications associated with open treatment. His first frames were constructed from local parts from a bicycle shop. He used clutch rings and K-wires to transfix a bone and anchor themselves to the rings surrounding the limb. So these rings were then fixed to one another in a very, very stable construct that was solid enough to hold the bone in a pre-desired position, strong enough for a patient to walk on it. And it's what he described as bloodless surgery. Original indications. So his original indications were to stabilize limbs, especially limbs that would have been had a high potential for complications if treated conventionally at that time in their low-resource, remote setting. This evolved. He took on other problems, expanded his indications, and namely what he reported is that during the correction of an ankylosed knee, he performed his osteotomy and accidentally left it in distraction. When he came back and took an x-ray a few weeks later, he noticed the formation of callus, indicating to him what was new bone formation in a setting of the iatrogenic distraction. And that's where this all began for him. So after about a decade, as he had progressed in his methods and his abilities, he gained a little bit of traction in Russia, but was mostly not highly respected for his measures. However, it wasn't until this Soviet Olympian athlete sustained a tibia fracture that went on to non-union despite a lot of surgeries performed in Moscow by Russia's best surgeons. And when he visited Dr. Ilizarov and was able to be cured, treated, and even returned back to high jumping, that's what really shot Dr. Ilizarov into fame in Russia and got him a lot more resources. A little bit less than a decade later, Dr. Ilizarov was still not yet accepted outside of Russia, but this is a publication, the first English language publication about him in a nursing journal out of Australia and Asia. And that just showed that his fame was starting to spread, but not yet to the Western world. He was able to break through that with this occurrence. Carlo Mori was an explorer, an Italian explorer who had known a Russian explorer through some expeditions, and he spent 10 years undergoing failed treatments by the best surgeons in Italy to cure him of an infected tibial non-union. So he finally took a trip to Russia to see Dr. Ilizarov. who took on his case. And this is a picture of them. Dr. Ilizarov performed a surgery under spinal anesthetic so that Carlo Mori could watch him perform it. And then they celebrated with a cigarette in the operating room at the conclusion. This is real. So then a few days later, he was up and walking. The frame was stable enough to support his ambulation, and his treatment, I think, lasted on the order of 6 months, and he returned to Italy. So after he returned to Italy, later that year, like I said before, Dr. Ilizarov, who was only supported in Russia at that time, or the Soviet Union, was getting a lot more resources within the Soviet Union. This is a construction of a large medical center just dedicated to his work and his research and his treatments. This was right around that same time. But the attention the explorer in Italy was able to gain for him led to him being invited to the locally hosted International AO conference in Italy that next year, where they decided to make it a special session with Dr. Ilizarov lecturing on treating non-unions, infections, and all of his special methods, which went over very well. So now I will get into the meat of my talk about the scientific framework before I turn over to Dr. Githens for the technical and the technique aspect. These are the principles that Dr. Ilizarov preached. This is what he attempted to prove in his science to back up what he was performing in patients. And it included rigid fixation, high degree for respecting and protecting the periosteum, the bone marrow, as he interpreted that as the blood supply to the bone, and also closely controlling and optimizing the rate of distraction and optimizing the frequency. This is a picture out of one of his publications that he later did for an English journal. It describes the varied methodologies he used to study two of those variables that I was mentioning before, degree of stability and degree of trauma to the bone's blood supply. So we're going to go through each one at a time. These were done in canine tibia. It was used as a model. And this on the left, if you look closely, those rings with the K-wires going through them are loose. So this is a model with minimal stability, loose wires, only 2 rings, and an insult to the blood supply. He performed a complete medullary osteotomy across the bone. And what this resulted in was a fibrous tissue in the interzone, right here. And not unlike a fibrous non-union of a fracture. As we go along to the second model, now the wires are tensioned. It's more stability. Complete osteotomy still. And what formed in the interzone was similar to a fibrocartilage. So getting closer to something like a callus that could potentially mineralize. And then number 3, more stability. He doubled the rings and the wires. And what he was able to show is this finally led to osseous tissue. This is histologically, this is bone. And on radiographs, that's what I showed you for one of the first slides. So with enough stability and his protocol for distraction, bone will form. And then he took it a step farther. He was very intricate about preserving the blood supply. So this is a partial osteotomy. He only took the osteotome 1/3 the way across the medullary canal, and he got osseous tissue to form twice as fast. Okay, and even one step further, if you completely respect the intramedullary canal, and you only cut the cortex on the near side, leave the intramedullary canal, then use an apparatus that curves around the cortex outside the periosteum to break the far cortex, leaving the whole inner medullary canal intact, he got the best and most robust bone formation under the same stability. And then he did some angiography to show that he was keeping the nutrient vessel intact through the medullary canal. And he used this actually to describe a fracture classification for tibial shafts too, where the amount of displacement likely led to trauma to the nutrient artery or the blood supply, and used that as a factor for classifying how long tibial fractures took to heal. And it was incredibly insightful for me just thinking about fractures, not only osteogenesis. Okay, so one step further, not only did they create bone when lengthening the tibia, but he showed that it can happen in any direction. So this is transverse. He's pulling the bone sideways, and he showed bone formation in a direct vector going along with the tension. Just to dig a little bit more deeply here. So these are some close-ups about what's going on in time. First, fibroblasts come in and they orient themselves once again in the direction of the tension. Then they put down collagen, once again directly oriented in line with the tension. And then the collagen is replaced by osteoid, directly in line with the tension. So everything is following that stress vector. It wasn't just the bone. All the cells changed. Their nuclei got bigger. They started to become active. The blood vessels started to align themselves. The smooth muscle within the walls of the blood vessels were aligning themselves and following the tension. That was what was spurring this growth. And then this is a treated canine tibia. This is the same animal's contralateral limb, their nutrient artery. This is all the intense angiogenesis that's occurring with the osteogenesis and following the tension. These are some electron microscopy pictures of the cells enlarging, and then the intracellular contents once again aligning themselves with the tension. These are some more zoomed out pictures. Everything is following the stress. That's what's driving this. Okay, and lastly, not only did the tissue grow, but it grew into the area. Nerves grew into the area. They were surrounded by Schwann cells. Skin cells were elongating. All the tissue was growing. Maybe it would be more appropriate to call this process not distraction osteogenesis, but distraction histogenesis, or the growth of new tissue via distraction. Second part of his experiment was refining the technical aspect of how fast do you distract and how frequently do you distract it. And he did a few different variables, or he used a few different rates and frequencies. And he found that too slow would create some distraction osteogenesis, but it would consolidate right in the middle of your process before you wanted to. Too fast would leave you with a poor regenerating bone and would even damage the soft tissue surrounding it. And it showed pathologic findings on the electron microscopy of cells when it was too fast. And then he tinkered with the frequency. They would distract once a day or 4 times a day. And even later on, he came up with a continuous auto-distractor that would slowly distract throughout the day. And he found that to be the most productive environment for bone growth, the higher the frequency of distraction. And it was most favorable for the soft tissues. Here are a few example pictures just to back up what I'm saying. This is when they went too slow. They started to distract, and it's not a complete straight osteotomy. They were breaking it on the other side. That's why this is a little jagged. But it would close prematurely in the experiment, so they weren't getting the length they desired. Here's an example of changing the frequency. This is continuous distraction. Forms a very, very nice regenerated bone, and these are all on at the same time. This is 4 times a day, which gets you a regenerating bone that comes along. And then this is once a day, which was very poor. And that's why all of their work was then at least 4 times a day, but ideally with his automatic distractor. Okay, and just to hammer this in with the bone growth, a lot of times in this interzone, a lucent line would develop, not dissimilar to like the appearance of a physis. And while this bone growth is not physeal bone genesis, it was very reminiscent of that to them. Okay, so I'm going to wind down here and then turn it over to Dr. Githens. But in summary, living tissue, this is directly from Dr. Lazarev, translated into English. Living tissue, when subject to slow, steady traction, becomes metabolically activated. the tissue, not just the bone, biosynthetically, proliferative in many different pathways, and it was his opinion that it was all dependent on the vascularity, and then clinically, when rehabilitating his patients, on the functional use of the limb. To briefly touch upon the indications, while it first started as closed fracture management, it soon went on to non-union treatment, both septic and aseptic, and even in the absence of antibiotics. He was able to lengthen bones and, through that, correct deformities. And not just in bones, his frames were used for joint contractures, used for osteotomy correction, and even to facilitate fusion joints. What really took off for him was the ability to create new bone to fill bone defects, congenitally, traumatic in many situations, and even expand the bone sideways, like the scientific experiments I was showing you. Maybe the most peculiar one was he was able to treat certain occlusive vascular diseases, and a very focal vascular disease where there was an arterial thrombus or embolus. The patient had a threatened limb. They were able to cut the bone, distract it right at that area, and over a few weeks get enough vascular genesis to create a flow pathway of new blood flow around the occlusion, which is pretty amazing. Everything I told you up to this point was pre-1990s. In 1997, there was the beginning of a shift in paradigm. Dr. Lazarev was crazy about respecting the blood supply, and as you can see, respecting the intramedullary blood supply. But it was Dr. Dror Paley, who was a chief resident at the time that Dr. Lazarev gave his first lectures in Italy. He was there visiting an international conference, and he and other folks brought back this concept to North America, and he really got going with investigating that on this continent. But he was able to show that if you place an intramedullary nail to supplement the lengthening, you could get it done a lot quicker, easier rehab, less time in the frame, better for the patient, get the same results, which is really fascinating because Dr. Ilizarov preached respecting the intramedullary blood supply. But as I showed you in the experiments, you can still get it done. So this now showed a change towards minimizing some of the complications that I'm sure many of you are aware of. Okay, thank you. I'll turn it over to Dr. Githens.
Well, thanks. Dr. Barron gave us a really nice tour through the history of distraction osteogenesis and where Dr. Ilizarov got us now. You know, when Dr. Barron first approached me with this topic, I thought to myself, well, my experience is you say Ilizarov and you see people's eyes sort of roll back into the back of their head, like, oh my gosh, we have to do this. But, you know, as we focus so rapidly on advancements, we kind of lose track of the history of where things came from. And I think that it's really nice to review the history of Dr. Ilazarov's work because it really created an entire subspecialty within orthopedics. And while we're not using these frames routinely, at least in the trauma world, the applications, as Dr. Barron told us, are really far-reaching and have really changed the way we deal with a lot of problems. So I think it's a really nice thing to review the history. I commend you on that. I'm going to start with a case. This is a case of one of my partners, actually. So this appears to be a pretty straightforward bicondylar tibial plateau fracture. It's a closed injury. We think, okay, anatomic reduction, internal fixation, and we're off to the races. But this gentleman develops a severe soft tissue injury, circumferential hemorrhagic blisters, worse and worse and worse, to the point where soft tissue resolution is going to take weeks, 6 weeks, 8 weeks, and by that time, this is going to be a real problem to treat open. And so the decision is made to go with a limited approach for open reduction of the articular surface, and then treatment of the metadiaphyseal component of this injury with a fine wire tension frame, i.e. the Ilizarov type of frame, okay? So I'm going to use this case and a few others just to drive home 3 main points. So number one, these frames are incredibly versatile. As Dr. Barron said, the applications are are far-reaching, and there's a very high success rate if they're applied correctly. That being said, even in the best of indications and the best of hands, there's a very high complication rate. Some of those are minor, some of them are major. And additionally, the management of these frames can be really, really, really challenging for the patient. So, point number 3, alternatives for a lot of these indications exist. And if you don't have to use one of these apparatuses, it's probably better for the patient. But when it's the right thing to do, it's the right thing to do. So the 2 indications that I'm going to focus on are acute fracture management and then management of traumatic segmental bone defects. I'll talk a little bit about the techniques, the advances that Dr. Barron mentioned, as well as some of the alternative treatment options. So for the 30,000-foot perspective, just to remember, when we talk about treating a fracture acutely, our primary goal is to restore function to the patient, to the limb, right? So on day 1 in the operating room, we think as surgeons, how do we optimize the biomechanics and the biology of that fracture environment so that, number 1, we can avoid infection, and number 2, get them to heal, and ultimately get them back and going. So the tensioned fine wire frame has advantages, and I'm referring to it because now there's been a lot of iterations after Ilazarov's to improve the technology, but at its basis, it's a tensioned fine wire frame. Has many advantages. One is its biomechanical profile. So any external fixator gives us relative stability, right? But this allows a really precise control of motion at the fracture site, which you'll see in one slide is really favorable for bone healing. Number 2, there's preservation of what biology is left at the zone of injury. With the application of this frame, you don't have to do no more surgical insults to the zone of injury, which helps to preserve the biology. Number 3, no implants are placed. At least they don't have to be placed in the zone of injury, so that mitigates the risk of infection. And then a very, very important point is a lot of times these frames are being applied for limb salvage. And so you're talking about months. You're talking about 5 months, 6 months, a year, sometimes over a year. And if you can have a patient who's walking during that time, you're going to mitigate the muscular atrophy that can occur over the course of 8 months and put a patient way behind. Similarly, they're going to have the ability to maintain some joint range of motion. And lastly, it's a dynamic treatment modality. So if there is a segmental defect that needs to be managed, it can be managed at the time. Or if there's a deformity that develops, it can be corrected at the time. So one slide on the biomechanics. These frames, because the wires are tensioned, they allow axial micromotion at the site of a fracture. They eliminate shear forces, and they really minimize the bending forces. So that creates a perfect biomechanical environment for fracture healing. Even in fractures that are oblique greater than 30 degrees, with some simple modifications to the frame, you can still convert what would clearly be a shear force across a long oblique fracture to a compressive force. And from a biomechanical standpoint, that's about as good as it gets when it comes to relative stability. So disadvantages are probably as significant as the advantages. Number 1, though, is you've got to have the right patient. Right? This is not a treatment that you can apply to anybody. And the reason being is the complication rate nears 100% for even the best of patients. Now, most of the time, what pushes that complication rate up to the ceiling is a pin site-related infection. So that can be a minor thing that's treated with antibiotics or a trip to the operating room for a pin exchange, yet that's still a complication that bears on the patient. The duration of treatment is another significant factor that I'll go into in more detail. Even in the best of circumstances, this is an extended duration of treatment, and that affects patients' quality of life. You know, walking around with a circular frame on your leg for months at a time affects all kinds of things that we don't even think about, including how do I get my pants on? I have to have a tailor make a pant leg to fit around this frame. So it can be really hard for patients. And then compliance becomes its own issue, especially if you're talking about bone lengthening or deformity correction. You're relying on that patient to make changes 4 times a day, every day for an extended period of time. And that in and of itself can be a huge burden on the patient. So in planning, Dr. Barron's kind of walked us through what makes these frames up. It's rings and then smooth wires There's also additionally, there's an olive wire, which is a wire that has a stop on one end, which can be used for reduction, and it can be used for compressing in vectors. Half pins are a modification that came after Ilazarov's time, and I'll talk about why we use half pins and where we use half pins. And then, as Dr. Behrens said, historically this frame was designed to have 2 rings for each main segment. Now with the addition of half pins and other things, that's been modified, but the idea is that you have at least 1 ring and multiple half pins, usually 2 rings for each main segment. And then if you're anticipating needing to do bone transport, when you assemble this frame in the acute setting, you design a ring for that segment of bone that you're planning to transport in a delayed fashion. Typically, we're pre-assembling these frames just so that you're decreasing the time in the operating room. So it takes a fair bit of planning to do one of these. Additionally, in planning, if you think about this is transosseous, transcutaneous wire fixation, which makes safe zones an issue. So learning and knowing your cross-sectional anatomy is very important. It's different at every level, and so you have to pay attention where are your safe zones to put these wires. It's another reason the half pins have been used. So from a technique standpoint, I'll go through this fairly quickly, but back to our case, this is a gentleman who has a bicondylotibial plateau fracture with a bad soft tissue injury. So step 1 is to get an anatomic reduction of the articular surface, right? So that's done with very small approaches, small implants placed percutaneously or through small incisions to minimize the soft tissue there to get an anatomic reduction, interfragmentary compression. Alternatively, you can get compression at the articular surface with the use of the olive wires. So step 2, and this is probably the basic that applies to applying these frames and in deformity correction or lengthening or anything, this is kind of the key step. So placing a reference wire parallel to the articular surface on all views, because this is going to be the reference from your frame beginning to end. So that's step 2, and it's very, very important. So step 3 is basically putting your reference reference ring off of your reference wire, both proximally and distally. And then you can imagine if you're correcting a deformity, you've got 1 ring that's parallel to the joint here and 1 ring that's parallel to the joint here, ultimately bringing them like this. So that's why you're referencing off of the articular surfaces. Step 4 is basically just to add additional stability and fine-tune the reduction. So adding additional olive wires in appropriate vectors, adding half pins. So the half pins are used essentially to replace the fine wires. They have a variety of benefits. One is they increase rigidity over the fine wires. 2, they generate less heat necrosis in the diaphysis when you're placing these. And 3, they allow fixation in unsafe zones. So if you know that you're safe on the front end, but there's dangerous structures in the back, you can place a half pin. They can also be used as steerage pins for the oblique patterns, as I mentioned earlier. And now one of the technical advancements that came along was the HA-coated pin, so that increases the durability of those pins, and a lot of pin site infections are related to pin loosening. So the HA pins are now standard of care. So in this step, we're ultimately achieving length, alignment, and rotation for the metadiaphyseal component of this fracture. And then in 5 months, his frame comes off, his articular surface is healed in an anatomic position, and the length, alignment, and rotation has been restored. So it's a very effective treatment. He's avoided infection, and the goals were met. So how about managing segmental defects? Dr. Behrens talked to us a lot about distraction, osteogenesis, and sort of the science behind it. In the clinical setting, if we're treating a fracture acutely in a frame and planning for bone transport, that typically is delayed. The reason it's delayed is to allow the environment to prepare itself for osteogenesis. Part of that is reliant on the soft tissue condition. So if you've got a bad soft tissue injury, you're going to need to let things settle down before you start distracting. Part of it depends on the host factor and how long they remain in a catabolic state. Are they able, from a nutritional standpoint, to actually start forming all of this new bone? So the osteotomy is really important, and Dr. Behrens sort of talked us through what's important about it. The idea is to create as little trauma to the blood supply to the bone, but still create a complete osteotomy. So that's typically done by making a subperiosteal incision, and then if you're in the metaphysis above where that main nutrient artery is, you can actually you perform a complete medullary osteotomy. But in the diaphysis, you really do attempt to... You attempt to preserve both the periosteal as well as the endosteal blood supply. Now, whether or not you're going to need a fibular osteotomy depends on whether or not you're ultimately planning on altering length or if you're planning on correcting any deformity. So the timeline, this becomes a big deal. This is where it becomes a big deal really for the patient. So that latency period that I talked about is somewhere between a week and 3 weeks, and that's again to optimize the osteogenic potential. And it depends on many, many factors. The distraction rate ideally is about 1 millimeter per day, and that's broken up into 4 lengthenings per day. Again, the rate that you distract depends on age and location of the osteotomy. So if you have a pediatric patient and you're distracting in the proximal femur, you can go a lot faster. If you have an elderly patient with an area of poor blood supply, then you probably need to go a bit slower. So continuing on with the timeline, at some point, you've distracted to the point where you're nearing docking with the far site. At that point, the standard of care typically now is to open that docking site, prepare the bone ends, and then do some bone grafting there. Once you've docked, then you attempt to compress at that site to generate healing, and then over time dynamize frame. So we've gone from the transport phase now to the consolidation phase. This whole area of bone that you've transported across is called the regenerate. So that regenerate needs to mature to the point where it can actually independently bear load. So that's the point of dynamizing the frame over time. Now the consolidation phase is, as I said, the maturation of the regenerate takes about 2 times longer than the transport phase itself. The frame is only removed after the patient can comfortably bear weight, and you see bridging on 3 to 4 cortices on orthogonal views. So if you think about this timeline, you have a 10 centimeter defect, you're looking at about 300 days in the frame, right? That's why this is so hard for patients. So how do we accelerate the timeline? That becomes a big deal, because if we can do that, then we reduce the rate of complications and it's much easier for the patient. So one way to accelerate the timeline has been the use of multifocal distraction. So you hear bifocal or trifocal distraction, which was actually developed in patients who had large diaphyseal tumor resections, and then they had that segmental bone defect reconstructed. So that's an osteotomy proximally, an osteotomy distally, and transporting in 2 directions. Now, in doing so, you accelerate the distraction phase by 2.5 and the consolidation phase by 1.5 times. So that's tremendous. In the trauma population, it's not often that we can do this for a variety of reasons, but mostly based on where the bone defect is. It's also technically much more difficult. It's difficult to manage. And the regenerate is of a significantly poorer quality, so these patients actually tend to have late deformities develop or refractures of their regenerate. Another way, as Dr. Barron mentioned, to accelerate the timeline is to transport over a nail. So once docking is completed, the frame can be removed. Now this nail can be placed at the time of the index operation, and you're transporting over a nail. It significantly decreases the time in the frame. It also, because you've got an intramedullary implant, decreases the rate of refracture of the regenerate. There are some studies that show it does prevent development of a late deformity. That being said, there are also studies that show that patients will end up with a proximal tibial valgus deformity with a nail in. There is some studies that suggest that there's improved functional outcomes in patients who have lengthening over a nail as compared to the traditional lengthening in frame. There's no difference in time to union or union rates using this method. Now in the trauma world, what we worry about is, well, we've placed an implant in that zone of injury that we were worried about, so does it increase the rate of infection? There's not really robust enough literature using this method in the trauma population for us to answer that question, but that's always something that sort of lingers as far as, is this safe or not?
Another way to accelerate the timeline is similar to the last, yet using plates rather than nails. And this can be done either by plating at the time of docking or pre-positioning the plates at an earlier time so that you transport your segment to the docking site and then you place screws into the transport segment. Again, the great benefit of this is that it decreases the time in the frame. What it does, though, is it unfortunately increases protected weight-bearing time because patients who are treated in this method have been shown to have failure, particularly into varus with plate breakage. So what you're doing here is you're taking the frame off, but then you're subjecting the patient to an extended period of time of non-weight bearing. There is also increased time to union with this method, and there's the theoretical risk of increased rate of infection. Again, hasn't really been shown, but something that we worry about. So to summarize, with the use of the fine wire frame, there is a high rate of complications. Now, most of those complications, again, are related to the pin sites, but regenerate fracture does happen, particularly in patients who have a large segment of transport greater than 8 centimeters, has a very high risk for a regenerate fracture. The pin sites themselves are not benign. You know, we're used to putting in traction pins for femur fractures, and that's not a problem. But these pins, remember, as the bone travels, so do the pins, and so they leave scarring behind. And those scars can be very painful, persistently painful for patients. And again, patients can develop delayed deformities through their regenerate. So what are the alternatives then? If we're just talking about traumatic segmental defects, we've got a lot of options. Some of them are more historical. Others of them have really sort of supplanted all of the other methods that we use. So acute shortening followed by lengthening is something that is successful as far as patients who have really bad soft tissue injuries. You can get primary closure and then lengthen over time if necessary. This is probably more effective than in the upper extremity where some shortening is tolerated as compared to the lower extremity. The induced membrane technique is something that we all have become increasingly familiar with and is probably the method that most of us are using now to manage most segmental bone defects. Vascularized autografts can also be used, and then the other path in this whole treatment phase is amputation. So I'm going to talk a little bit about the induced membrane as an alternative for management of segmental defects, and then we'll wrap it up. So as you all know, the induced membrane is popularized by Masquelet. It's a two-stage treatment for segmental defects, and the authors, when they first described their experience, were treating segmental defects from 5 to 24 centimeters, so a really quite large defect. Stage 1 is placement, after an adequate debridement, is placement of a PMMA spacer with or without antibiotics. And stage 2 is spacer removal followed by autograft bone with potential expansion of that with allograft. So just as a review, why does this work? Why does this work better than simply just coming back to do an autograft? Well, Dr. Masquelet found that when you leave a PMMA spacer in, you develop a biologically active membrane at the fracture site. So there's 3 main things that he theorized why this actually helped as far as getting patients to union. Number 1, it creates a privileged space. So bone graft resorption is a problem at not an anticipated or a non-union site. This creates a privileged space which seems to minimize or decrease the rate of bone graft resorption. Number 2, it simply maintains a physical space so that when you come back, you have an easy, accessible physical space to bone graft in. And number 3, and probably most importantly, this membrane is biologically active, with all kinds of cytokines and other factors that really are favorable for bone healing. So Masquelet treated these defects 5 to 24 centimeters, and his grafting time was on average 6 to 8 weeks, and he achieved an 89% union rate. Some folks have followed up his results with other studies and have had success from 85 to 100%, with the primary outcome being a union, not necessarily union without additional interventions, but ultimate union. So the advantages, it's reliable for large defects. We know that. There's decreased rates of reoperation as compared to bone transport. One of probably the most interesting and compelling advantages is that the time to union is relatively independent of the size of defect. So you've got a 5 centimeter defect and a 20 centimeter defect. If all goes well, you can expect those to heal in relatively the same amount of time, whereas if you're talking about bone transport, there's a significant increased time to union based on the size of the defect. There are some limitations. Patients still do need reoperations. There are still complications. Some reported up to 50% of patients suffering from at least one complication. One of the primary technical limiters, though, is the amount of bone graft needed. So ideally, we're using autograft bone. And if you have a defect that's, say, 24 centimeters, where are you going to get 24 centimeters worth of autograft? So we know that we can expand with allograft up to a 3-to-1 ratio, but sometimes this is still a limiting factor. And then based on where the defect is and what implants you're using, you may be looking at prolonged limited weight bearing, which, as we discussed with the fine wire frames, is not really an issue. So just to go back to a few of the issues that we continually talk about and debate as far as the Masquelet techniques and the finer details. What about the timing of bone grafting? So Masquelet, when he wrote his original series up, didn't really have any formal protocol, and we kind of stuck with this 6 to 8 weeks because that was what was done, and that's what worked. So as time has gone on, we've started to look a little bit more in detail as far as, well, what's the optimal time in order to come back and bone graft from a host standpoint and from the local biology. So there's some fairly compelling studies that have come out over the last few years looking at when the membrane is most biologically active, therefore probably best prepared to receive bone grafting. And it turns out that it looks like in humans it's probably closer to the 4 weeks to 6 weeks mark rather than the 6 to 8. So there's been a lot of talk about, well, perhaps we should be coming back and bone grafting these patients at 4 weeks rather than 6 weeks. Now, part of that depends on the condition of the soft tissues. If you have a flap that's still maturing, then you're not going to be able to come back at 4 weeks. But in the ideal setting, a lot of scientists are starting to propose bone grafting earlier. Now, interestingly, just this last month, there is a supplemental article in the Journal of Orthopaedic Trauma written by Dr. Masquelet. And in that article, he suggests that the biology of the membrane is not necessarily optimized until you come back and stir it up in bone graft. So he in this paper says 2 months to 2 years may be just fine. So I think this question is still one that needs more research as far as answering it goes, but ultimately we're going to try to bone graft as early as we can as the soft tissues allow us. The other question that has been kicked around is, what's the role of antibiotics and how do they affect this process? So the bottom line is we don't know, but there's some ongoing research as far as how do the antibiotics, number one, affect the membrane and its biology, number two, affect the bone graft and its biology, and number three, how does it affect rates of infection? So we don't know. There is some basic science that's coming out showing that antibiotics probably do have an independent effect on the biology of the membrane, and certain antibiotics more so than others. It looks like probably gentamicin combined with vancomycin is synergistic both for the membrane as well as for treatment of the common bacteria that cause our infection. That being said, in this same paper, Dr. Masquelet rides a pretty hard line on not using antibiotics. So his original protocol, and to this day, does not include using antibiotics in the cement spacer. And he says for several reasons. Number one, we could be increasing bacterial resistance. Number two, we still don't know what it does to the membrane. And for those reasons, he rides a hard and fast line not to use antibiotics. So those are the two questions that we're kind of working through as far as how to optimize the Masquelet. We know it works great for big bone defects, and that's why we're seeing probably less and less use of the Ilizarov type of frames for managing segmental defects. I think their role primarily in the trauma world is still for management of non-unions with deformities, as well as as well as treating post-traumatic infections where there's a requirement for a large segmental defect to be created in order to clear the infection and then transport bone. So in summary, these tension fine wire frames have very broad application. They can be used very successfully. They have distinct advantages as well as distinct disadvantages. They're an excellent method for treating segmental bone defects, yet there are alternatives that we're using very effectively now. So the induced membrane technique is probably supplanting the fine wire frame as far as managing segmental defects. But as I said, these frames still have their role as far as treatment in traumatic problems. Thank you.
Thank you. That was great. We have a few minutes for questions. Vince, do you mind if I just start with the texted questions for a second? So this is from Harborview, Mike, you sort of addressed it at the end, but the question is, who is the ideal patient for rings and transport? Are there any absolute contraindications? And then the second part of the question, and this is from Lisa Tatesman, is how do you decide rings for transport versus mascale?
You know, it's a tough question to answer. Who's the ideal candidate? I think that as far as transport goes, in large part, that's dependent on one's experience. If you're very experienced in using these frames, comfortable with managing the patients long-term, and have had success with it, then you may default to it. The majority of us, though, are using the mascale technique even for very large defects. Now, part of what may push your hand towards using a fine wire frame is the condition of the soft tissue and the question of whether or not you'll ever be able to go back and bone graft. If based on the soft tissue conditions you think that there's not going to be an opportunity ever, then bone transport with a frame is probably going to be better than the mascale technique. Absolute contraindications, yeah, I'd say a patient who's not going to tolerate that frame, who doesn't have the social support to deal with it, who has, who's going to fail because of social issues.
I thought those were great talks. This reminds me of about 3 decades ago when we first started talking about this here. And Matt, I thought you did a great job with the history. You only left out a little bit of history, which is really to talk about the contributions of Jor Paley. And I don't always sing his praises. He's made a lot of contributions. Among them are the fact that the hybrid frame was a Jor Paleyism. So Jor Paley is Canadian, and he was a chief resident when I was a fellow in Toronto, and he was a fellow when Chappie Conrad was fellow. They were in the same year. And Jor Paley, he's a driven person, as you know, and he went to Italy in the mid-'80s and found out what the Italians were doing with monolateral fixators. Then he heard about Ilizarov, and he was the first North American to be allowed into the USSR to visit Ilizarov in 1988. Were you guys born in 88? So in 1988, he was the first North American allowed in. He saw what Ilizarov was doing, and he was the one who came back and decided that no way could we just build the frames on the patients. He was the one who came up with pre-construction. He was the one who used the Italian half pins with the Russian rings and wires to make the hybrid frames. And he taught Ilizarov to Americans. I spent 2 weeks with Ilizarov in 1989, the next year, and we operated together. They smoked in the operating room. We reused the gloves and built the frames on the patients as you go. No pre-construction. So everything that we do now with the rings is really Jor Paley's contribution to this that happened in your lifetimes, but not much before. So I thought that was important. And to say about the infection too, I'm not a mascale or bone transport person, but the reason that Ilizarov started this was not to make dwarfs taller. It was because after the war, there were infected non-unions, including Valerie Brumel. And with distraction histiogenesis, he healed the bone, cured the infection. There were no antibiotics in the 50s. In fact, when I was there in 1989, you could only get antibiotics in the Soviet Union on the black market. So the frame was designed because by moving the tissues around in a controlled fashion, got the bones to heal, got the soft tissue to do what it's supposed to do, and cured infection without antibiotics.
Thank you.
Mike, Matt, good job. That was interesting to hear. Quick question for you now. With the advent of the telescoping nails and the remote control of these nails, do you think there's still a role for using frames for limb lengthening when there is no deformity?
Well, interesting you said no deformity, because there was a recent paper in the past year where they did the telescoping nail but pre-planned the distal segment of bone in a translation angulation so that it would heal a deformity too. As Dr. Bouchard knows, there are some situations where you can't use the telescoping nail depending on anatomy, the size of the canal of the bone, and it's mostly technical aspects, but the all-internal thing is extremely exciting as well, because that mitigates almost all, not all the complications, but a lot of them, having an internal splint and having nothing coming out of your skin.
I think as the techniques evolve and the familiarity with the new devices evolve, we'll see less and less of the fine wire.
Thanks for bringing up the topic, because I think we don't talk about this tool enough here. There's a lot of options just within the frames as well, just tailor spatial frames, so multi-axial frames that give you a lot of extra options, and then the internal nail. But I think the key thing is it's maybe not always the bad solution if you end up picking it. Sometimes it's really the right solution for the patients, and they give you a lot of versatile options to treat deformity, to treat length defects, and even to treat acute fractures, especially in adolescents with open physes. Frames can actually be really powerful for diaphyseal fractures. You can put on a tailor spatial frame, leave it unreduced, unlock all your struts, get it reduced, hold it out, lock them, and then for fine-tuning, run a program. So you've got a lot of really interesting options. The nail, as you said, Rainer Baumgart in Germany is the one who's really done a lot of acute deformity correction with lengthening with the nail, and you just use your blocking screws like you would with a trauma nail, and you can do a lot of distal femoral deformity correction with that. But I think it's important that patients don't necessarily have a bad time with the frame. You just have to approach it correctly. They need really good support in terms of the provider, their team, physical therapy. And I think as the provider, you need to anticipate the complications, and if you anticipate them, you can actually minimize them quite a bit. Preoperatively, like you said, selecting the right patient, but lots of good pre-op education and preparing them for what it's like to live with a frame or even live with an intramedullary nail, because there's still a lot of physical therapy and a lot of intense rehab with the nails, and they're still non-weight bearing until they have 3 cortices of bone, which can be at least 6 months depending on your defect. And then intraoperatively, your pin placement is critical. The half pins have really changed the way patients feel. You don't have as much skin tension, you have fewer infections. And postoperatively, now I have a team with a PT and a nurse and a PA, and we see them every week to every 2 weeks, and a lot of psychological support, group support within the patient group, and they do well, and post-op pain is not quite as scary as it was with some of the other devices. If you put your pins in the right place, and most of my kids are actually not on any pain meds after the acute post-op period. Adults are a little bit, I think the tissues don't stretch as well, they require a little bit more, but it's actually not quite as invasive, perhaps, as it sounds. And again, it gives you a lot of options you can't get with acute correction. So I think it is a really good thing that we've brought it up, and I think there's a lot of options for our patients, and keeping that in the back of our minds is really critical.
Thank you.
Okay, go ahead.
I only had a short global comment, and that is that I took Calvin Schlepp to Bangladesh last year. At the single trauma hospital, they did 114 Lazarev cases a month. And during one spine surgery, they did 6 pseudoarthrosis of the tibia fixations during the one surgery that I did. So they're very, very slick about it. And the other is that the cost is less than $100 per case. And I think that becomes huge. And remember, there were about when the history of this is so interesting, because there were 3 billion people to be influenced by this single Siberian doctor. And that is still permeating into all of Southeast Asia and China and India. So I just, you have to really put it in perspective.
Thank you.
So I have a different sort of question. You know, one of the things we all are dealing with is trying to get bones to heal, trying to regenerate bone. And so there's this powerful but challenging mechanical technique. Has there been any progress in understanding how this actually works biologically? I mean, at some level, it has to be a mechanical force turned into, you know, a biological signaling pathway. And so then you start to think, you know, can this lead to other ways to enhance bone healing that, you know, don't involve, you know, year-long surgical procedures in essence?
Wow.
Sorry.
Yeah. Well,
Something to think about if you don't have the answer.
yeah, obviously it's something to do turning on the cells, maybe at the level of the stem cell or whatnot. And I studied perimatrix, chondrocyte perimatrix science in college, and there's a vast mechanical structure surrounding these types of cells that are influenced by biology, and I think that's just scratching the surface, and I don't know how you turn that on with tension, you know, without actually pulling things apart, but there's something to it.
Thank you.
Time?
Yep.
Two quick questions. Several years ago, to reduce the pin infection, some companies are selling silver-coated pins. I don't know whether anybody uses that. The second question is, in the very initially, if the whole cortex is not there, we can apply distraction, but there is no material to resist stress. So there is really no stress unless we are talking about the endosteal membrane. So maybe, you know, depending on how soft, in a week or two the tissues form, stress levels would be very different for the same amount of distraction.
I should add, Dr. Saha, do you want to introduce yourself to everybody?
Oh, I'm sorry. My name is Shubhradhar Shaha. I moved to Seattle from SUNY Downstate Medical Center just about a year ago. So I have been director of orthopedic research at LSU Medical Center Shreveport and at Loma Linda University and at Downstate before I came here.
Thank you for coming. I don't know about the history of the silver part, but
Yeah, so I have not, and I haven't seen any of my partners using silver-coated pins, so I can't speak to that.
Does Maurice know?
No, it stains the skin a lot, so the HA has definitely been the way to go, or just the classic stainless steel.
The hydroxyapatite.
Yeah.
and the second part is very insightful. What I didn't talk about and what Dr. Githens talked about briefly is that you have to wait a few weeks to create some sort of environment that you can influence the tension across, and I'm sure that's extremely key.
We should also mention that this is being used also for the oral surgery
Yeah.
to remove the mandibles, you know, distract. So its application is really much more beyond orthopedics. Thanks.
Thank you. Anybody else? No, that's fine. All right, thank you. Thank you, guys.
Thanks.